I tell them they're vaginal estrogen virgins. So most of my patients who come to me haven't ever had vaginal estrogen and they've just been suffering. And so it's quite easy to say, oh, goody, you've never tried anything. And so you can just try vaginal estrogen and it will help you.
This is Med Spa Mayhem, the podcast all about the chaotic world of medical aesthetics. From Botox to lasers to IV bars, learn how to tell real versus fake, legal versus illegal, and safe versus potentially deadly. Hear the crazy stories inside the med spa world and find out what questions to ask and how to spot the people cutting corners. I'm your host, Dr. Kate D. Together, we explore the wild west of medicine that is the aesthetics industry. Hi, this is Dr. Kate D, and I'm joined today by one of my great friends, Dr. Naomi Bush, a specialist in menopause medicine, and we're going to talk about menopause today and hormones and a few other things. So Naomi went to Tufts for undergrad and for medical school, and then did her family practice residency here in Seattle at Valley Medical Center, and has been practicing for over 20 years. Thanks so much for being here today, Naomi.
Thanks so much for having me, Kate. I look forward to this conversation.
So I would love to just have you tell your story about how you got down this path into menopause medicine, because our audience, probably many of them, knows that it's been a neglected part of medicine for women. And there's been just a huge demand for a reckoning almost in medicine. Hey, take care of us. And so how did you end up setting up this menopause practice?
So the best part of my story or my journey to menopause was that it was my friends who I've also been in a book club with for 20 years. So it started the beginning of my residency. And so we've aged together. And about a year ago, somebody started talking about how she didn't want to go into menopause quietly and that she felt that we should start talking about it. And then everybody just looked at me for the answers. And of course, I didn't have the answers. We don't talk about menopause really in family practice, gynecology, primary care, medicine in general. We really haven't been talking about menopause since 2002 with the Women's Health Initiative. And so I started on this journey to educate myself so I could teach my friends. And then I needed a place to refer them. And when I did a Google search, I couldn't find anybody who was either in private practice or just accessible, who was an MD or DO. I could find other practice providers, but I really wanted to send my friends to somebody who was an MD or a DO. And so I decided maybe I should do it. And my whole career has been me making that leap of faith into areas of medicine that I couldn't find help for my patients or my friends. And so I did. It was a long journey, but I did it.
I think it's fantastic. There's been a dearth of menopause care in kind of all over the country, but here in Seattle, for sure, there's just been very little available. I'm curious, so to help our listeners know why that year 2002 is so significant, because I know, but so basically that Women's Health Initiative study was going on for a really long time. Maybe you could talk about that and what the results were that happened and what happened to hormone therapy and menopause care after that.
Yeah, so leading up to 2002, lots of women were getting hormone therapy. Usually at that time, it was oral conjugated equine estrogen, otherwise known as Premarin, as well as medroxyprogesterone acetate, which we usually call MPA to shorten. And they were both oral, and that was the brand name Prempro. And what people were seeing in observational studies and case control and different kinds of retrospective studies, like other studies, was that there looked to be a lot of benefit to hormone therapy, that these women seemed to have less heart disease, less cholesterol elevation. They were basically doing well entering into this time of life where a lot of other women were starting to see an increase of heart attacks and cholesterol. So they started the study with the question they were asking was, can we give hormone therapy to prevent heart attacks in women? And the reason why that's important is because women have a very high risk of heart attack after menopause. And so that's what they were looking for. And it's important to remember the question they were asking, because they weren't asking, does hormone therapy cause breast cancer? They weren't asking a lot of other questions. That was what they were specifically looking for. And it was a randomized control trial that was prospective. So they enrolled women and they watched them forward through time. The other thing that's important to know is that they enrolled women without any symptoms of menopause. And the reason they did that was because if you give somebody hormone therapy and their hot flashes get better, then they would know that they were on the medication and not in the placebo. So then it would effectively unblind the placebo. So that was the idea behind like why they did it the way they did it. The average age of the Women's Health Initiative study was 63, and all women who were enrolled, for the most part, had no hot flashes or vasomotor symptoms. And then it was stopped early, and the reason it was stopped early is because it had two arms. One was estrogen-only arm, and one was the estrogen plus medroxyprogesterone acetate arm. And the estrogen arm actually showed benefits in heart disease and also benefits actually in breast cancer rate. Like there was less breast cancer in that arm. But the other arm, the estrogen plus medroxyprogesterone acetate, showed an increase in heart attacks. And since that was like the primary reason why they were doing this study was to show a decrease or no harm, they stopped it. And then they looked at it early and they looked at that arm. And in that arm, there was also an increased relative risk of breast cancer that was not statistically significant, but almost reached statistical significance. And then it reached the ears of reporters in the New York Times. And they said, oh, yeah, it's a 26% increased risk of breast cancer in the progestogen arm, the medroxyprogesterone acetate arm, when really that might have been the relative risk, but it was not it wasn't statistically significant. Anyways, it's been over time, it's really complicated. And over time, they've done a lot of follow-up studies on that study, and they've basically debunked it. And what that means is when they went back and looked at, let's say, the breast cancer risk, and I like this fact the most about the WHI. And if it was just one thing people needed to understand, especially if they know about science or journals or statistics or placebo controls, is that the control group did not, when they were controlled for heart disease, but they were not controlled for breast cancer. So that wasn't the primary question they were asking. When they went back and they looked, and then they recontrolled the control group for previous use of hormone therapy, family history of breast cancer, personal risk of breast cancer, it lowered that risk of breast cancer to basically null. So it wasn't so much that the people who were getting the hormone therapy had more breast cancers as it was that the placebo group less breast cancers. And so they were,
because of the way they were selected.
Exactly,
Yeah.
by the way they were selected. So it's like really hard to wrap your brain around. But in the end, I guess what I would say is that we can't use the WHI as a gold standard that it's being used as, and that there's been plenty of talk since then and plenty of studies since then that have disproved most of what that study tried to say negatively. We do know some things.
Yeah.
We know good things. We know that it was the beginning of, yes, estrogen can reduce your risk of heart attack. And from there was many other studies that looked more closely at that. And they do show that estradiol, which is what we use now, has a similar reduction in the risk of heart attack and plaque buildup when used early in the perimenopause or early in the menopause time before there's already plaque laid down. And I feel like that's a good thing that came out of that study.
Yeah. So to try to simplify all of that for people who may not have a PhD in statistics, I think understanding medical trials is really hard. And I personally think that it's something that reporters don't really do all that well. So they just want a bottom line and they tend to sensationalize things. But what happened in 2002 was before that, almost everyone was on hormones. Okay. Back when I worked in breast cancer, the vast majority of women who were postmenopausal were on hormones. And then after 2002, because of that study, all those people were taken off their hormones. And I saw people every year who were utterly miserable, okay? Miserable. And they couldn't sleep and they were depressed and they had menopause symptoms of various kinds. They experienced vaginal dryness. So we moved into this new era where you just had to suck it up. And I think doctors overall, right? Doctors overall said, we're done giving people hormones and women are just going to have to suffer. And that's the last 20 years. And now I do believe that most doctors understand, or many doctors understand, that study was essentially debunked and not helpful. And so more and more people are able to get some hormones and be able to deal with their symptoms and all the stuff. So can you talk a little bit about what you do for people, like what your initial consultations, like what you sort out and how people decide whether to go on hormones or not?
Yeah, I would say also before that, I think the other thing that study did is it left a hole, meaning people who wanted hormone therapy could not turn to their doctors for it. And so they had to
Yeah.
turn to alternative practice. And coming back from that is very difficult for the doctoring community, I think. Anyway, so for me, what I do is when people come to see me, they come to see me for all different reasons, but the typical person is usually not menopausal yet. Usually they're perimenopausal in their late 40s, typically. I do have some younger people and some way older people. And I guess that first consultation, I just listen to them and do a menopause checklist, which I think is very important if you're seeing any kind of menopause specialist, that they have some kind of objective data they're using to track your symptoms. And usually when they do that checklist, people will discover other symptoms that they were writing off to getting, I'm quoting, like old, right? And so they'll find other things. And so after that, after give them a good long while to tell me their story about how they went to their primary care doctor, how they went to their gynecologist, and they got put off into this is a natural process, or you're not old enough yet, or you're not menopause yet, then we talk about what their options are in terms of what their goal for treatment is, depending on their symptoms.
And I can just from personal experience, I don't think so. I was going through my 40s during those years of nobody's on hormones, and I had all kinds of symptoms. I just sucked it up, and I didn't have any change in my cycle. I couldn't sleep. I had sweats at night, and I also had a lot of pelvic pain, but I don't think I realized that all those symptoms were of perimenopause. I had them for so many years. So is there anything you can do during that phase where you're still cycling, but you're having all these symptoms?
So depending on what the symptoms are, you can do hormone therapy. So there's a few different options. And the first thing a lot of people will be offered is contraception, right? Oral
Hmm.
contraception, like oral pills, which is ethinyl estradiol usually, and some kind of progestogen. And the reason why most doctors offer that first is because people still need contraception during perimenopause. And so if you're having
Right.
hormonal symptoms and you also can get pregnant, if that's who you are, then that would be not a bad option, because the reason why people have so many symptoms, one of the reasons why people have so many symptoms during perimenopause is the theory is that it's the fluctuation from the highs and lows of estrogen. And so if you
Hmm.
can bring those back together so that you don't have such highs and lows and it's more of a steady state, then maybe some of your symptoms will resolve. And that's where the birth control pill comes in. And a lot of people use very low doses that are very safe. But if you don't need contraception, if that's not your issue, then the next option would be to use hormone therapy. And it's much lower dose and it doesn't control your cycles. So again, if you're having heavy periods or other reasons why you might want to control your cycles, it's not going to do that for you. And it still will help to control your symptoms. And that the theory there is that if you're using full menopausal hormone therapy with both estradiol and progesterone, then it's basically catching you before you bottom out. Well, your estrogen might go from 100 to 37.5, the patch, but it won't go to zero. And so you're still bringing those two numbers closer together and the symptoms will be reduced. Other people don't use any estrogen at all during that time, other practitioners, and they only use progesterone because sometimes the major symptoms at the beginning, especially early perimenopause, will be sleep, mood, mostly.
Hmm.
So then progesterone can really help with those two symptoms. If they're having hot flashes or other symptoms on their checklist, a lot of times they will benefit more from adding estrogen to that.
And then can you also explain to people about being on estrogen only if you have or do not have a uterus?
Or they don't have a uterus, one way or the other, and they don't need progesterone because progesterone is typically used for protecting. I just said a second ago that you can use progesterone only for early perimenopause, and that's for mood and sleep. It has nothing to do with the combined estrogen, progesterone, and using progesterone to protect your uterus. And that story is that if you think back to what is happening with our menstrual cycle and why we have estrogen around, estrogen goes to the uterus and gets it ready for implantation for when you have an egg released. And therefore, the lining of the uterus gets nice and thick and lush. And without progesterone, it'll just keep growing. And I always tell my patients, this is one of the things I tell everybody. Now everyone will know and they'll be bored when they come see me. But I always tell them it's like the grass, right? And so you want your grass, the estrogen is the grass and it's growing and it's nourishing the grass, but you don't want to look like your neighbor's grass and you don't want to be overgrown and weedy. And you want progesterone to come and to mow the grass and to keep it very nice and smooth. And then when you take away the progesterone and estrogen, that is when you would have a period during the menstrual cycle. And if you're using hormone therapy, that still happens when you're in perimenopause because estrogen and progesterone do not alter your menstrual cycle. And so you will still have your period. Anyway, so that's the story. And I think the reason you need to take it is because if you overgrow the grass and you know what that looks like in your neighbor's yard, bad things start happening. And in medicine, we call that endometrial hyperplasia. We don't want that. That's when the grass overgrows because eventually over time, if left to its own devices, can become cancer.
So if you still have your uterus, you can't just go on estrogen only because that stimulates the endometrium too much.
Right.
You need the progesterone to protect you from that. So
And you
yes,
can use
the progesterone,
progesterone.
like the lawnmower.
The lawnmower, yeah. I
Well,
always like to think of it as like all of the teenagers. It's just lots of teenagers coming by mowing the lawn all the time. But the other thing is that some people can't tolerate progesterone, that molecule, progesterone. And so I guess that leads us a little bit to with that poll I was talking to you about, like where there was this dearth of, there's no MDs doing hormone therapy. And it was like the rise of the bioidentical hormone therapy idea. And
yeah, I'm really interested. So can you explain to everybody what bioidentical hormones are and why we both have a thing about it?
so, yeah. So somewhere along the way, and I can't remember the beginning of the story, so I guess it's not that important, but someone found that in wild yam, there was this chemical backbone that you could build estradiol and progesterone. And the molecules they could build were exactly the same molecules that are made in your body. Through organic chemistry, they figured out that you could take this sterile backbone and you could tweak it and you can make estradiol, you could tweak it differently and make progesterone. And those molecules look exactly like what you make. And that's what bioidentical means. It's identical to what your biologic is making. That's different than what I mentioned before, hydroxyprogesterone acetate, which is a synthetic chemical that your body sees as not the same, but that it can have some of similar effects at the level of the uterus to try to help prevent that overgrowth. But yeah, so that's all that bioidentical means. And so it's a marketing term that people have been using for the last 20 years to make you feel that it's safer. And then, which it is safer. And it's also made in a pharmacy. You can also get it from a regular pharmacy, or you could get it in a compounded pharmacy. And the reason why you and I would say we should get it from a regular pharmacy, right, is because we know what's in it. And we know that's the formulation, that powder or whatever's made into that pill is bioactive, and that we know how it's going to react in someone's body because it's been studied. And in the compounding pharmacy, every compounding pharmacy has its own way of taking the powder that is estradiol and making it into a pill, a gel, a cream, a vaginal suppository, however they want to put it in there. And they're telling you that this is the same bioactive ingredient, but you don't really know how it's going to work with all of the different components that they're mixing it with. And the best one to look at is progesterone. I don't want to get too into the weeds of chemistry, but it's like making sure that you have something that is effective. If you take a progesterone that is not effective, you can end up with endometrial cancer. So it's really important that you're on an effective mix.
And so but the bottom line though is that it's bioidentical, and the bio part doesn't really matter because it's identical. So it really doesn't matter where you're deriving this molecule from. It's produced in a lab either way, right? It's the same.
And actually, like what they use in a compounding pharmacy, the powder is the same. It's exactly the same. It's from the seed plant. It's derived in the same place, and it's just sent to two different places. One goes to the pharmaceutical factory to make estradiol tablets. The other one can go as a powder to the compounding pharmacy, which they can then compound any which way they want. It's the same stuff
Right. So basically, what we're debunking a lot of stuff today. So basically, bioidentical hormones are just plain old the same hormones
as what your body makes.
as what you would get from a pharmacy.
So you could say,
And
yeah,
then, so I do think we've talked a little bit on the podcast before about different kinds of compounding pharmacies, and some are better than others. And you have to be careful and use a really good one if you're going to get a compounded drug. It doesn't mean it's bad or not going to
no,
be
I use
effective.
compounding
But
pharmacies all the time for different things. It's
yeah,
just, I want people to know that if you're going, this is my pet peeve, is if you're going online to a telehealth company that only uses compounded pharmacy that they own, and they are branding it,
right,
their name on it, and then charging you $100 a month. Even if you wanted to come to
right,
me and get compounded pharmacy, I probably could get it cheaper from our local compounding pharmacy. And that's my biggest pet
right.
peeve is there's nothing special about what they are giving you. You can get it anywhere, and there's no reason for you to be spending so much money unless you live somewhere where there's just no access.
Exactly. Again, so if you're paying a lot of money extra for bioidentical hormones through any channel, it's basically they're taking money from you for you're not getting any special health benefits out of that. Okay.
And I don't want to
Uh,
beat telehealth companies because there are quite a few good ones that don't do that.
mhm.
So I always tell people if they do that, this should be a red flag. That's how they're making their money.
Right. Yeah. Yeah. Totally get that. So what about other hormones like testosterone? Do you prescribe that, and under what circumstances, and what is that helpful for?
Yeah, so I prescribe testosterone. Again, so testosterone lives a little bit in this gray area right now where there's a lot of research being done today that won't be available for the next 5 to 10 years. And so we have to do our
Mm,
best by women to use what we
mm,
know and to try to do things safely. And so for me, that means if somebody comes in, so what is testosterone approved for by the Menopause Society in the United States? And what testosterone is approved for is for low libido, so hypoactive sexual desire. And that means not only low libido, but that it has to be distressing. So you have low libido, low sexual desire, and it's distressing. That is an indication for testosterone. And that is the only indication for testosterone today that is endorsed by the Menopause Society. So many people will follow that recommendation, and that is totally fair and legitimate. I tend to live in the gray zone because I know a lot about the data. I've looked at the metadata from testosterone, and while it's very difficult to study things like mood, fatigue, concentration, right? And so it's very hard to study those things. And so the metadata does not support using testosterone in those areas. And I would say that if someone comes to me with those things and they're on hormone therapy, they're already on estradiol and progesterone, and they're doing really good in some areas, but they come to me and they say that they're just feeling very tired. They're having a hard time concentrating. Maybe they have some low libido as well, but it's not overwhelming to them. Then I think that testosterone is a good option to try because it is psychoactive and we don't know how it affects the mood. And it's very little harm will be done if you use the right dosing. And that's where I stand. So I give my patients a lot of education around it. I always check blood work before giving testosterone, and that's just the total testosterone, just to know where we're starting from. And then when we do testosterone, it's a very small dose. It's 1/10 of a male dose, which means that, again, you can get it compounded, which I do use compounding creams for that, or you could buy it at the pharmacy and you would use 1/10 or of a male dose, which is fun to try to communicate to somebody. And then you check it again in 6 to 8 weeks and you see how is the patient, how are the levels? And so if someone's levels are overeating what is normal for a female, then that's a conversation of like, how are you doing? Usually we dial it back a little. And so I just go by that. And then if you ask me like, what are the side effects? Acne, hair loss, hair where you don't want it. And so usually if
Sure.
people's levels are too high and they start getting those side effects, they will stop the medication. Nobody wants those side effects.
No, absolutely not. Although You find, though, with that really low dose that people are experiencing that very much?
No, very rarely. I
Mm.
had maybe one person who had it, who experienced that at a low dose, and she probably had a higher testosterone starting. And again, then I just tell them to take it every other day, do it every other day, right? To try to
Mhm.
reduce it. I think that's why myself and many people in the menopause world do not agree with pellet therapy. Because when you do pellet
Yeah.
therapy, what it is, it's compounded and usually testosterone. Sometimes they'll put other things in there, but usually it's testosterone, and they're putting a pellet in that has all of the testosterone that you need to take for the next 90 days. And so we can't control. So if you think, okay, great, I'm getting
Is
1 milligram per day, so I have a 90 milligram pellet. But how do we know it's coming out that steadily? If we check levels on some people, you'll see their levels are way high. And
Yeah.
some of them have
And
side
you can't
effects.
take those out, right? You
I don't
can't
think
take
s
those out.
I don't know. I think that
Yeah.
sometimes they can sometimes people have fished them out, but I don't. And even when you take them out, because they're not they probably have broken up, people will continue to have
Yeah,
high testosterones for months later. And they work
right.
well for some people, and so that's where there's a lot of hype around it. But then for other people who it did not work well at all, they are like they're just silently suffering, and so nobody talks about them. So
Yeah. Maybe for men, it would work better. I mean, if their
I think
levels are
that probably I don't know. It's funny. I don't know really anything about men anymore.
we're
Um,
not here to talk about male menopause, but yeah, okay.
I do think that men do that, but I think also they might have the same issue where
Mm.
if it's too high for a while.
Right. Yeah, I think pellets don't make a lot of sense to me just because physiologically I don't understand how a slow release is even physiologically possible from that.
Yeah. Over
Um
90 days, right? It's a depot.
Yeah, I don't
No.
yeah, it doesn't make a lot of sense, but so we haven't talked about Mirena IUDs or other IUDs with hormones in them. Do you ever deal with those? And
Yeah, a lot of people, I would say percent, I think that's this around 20% is the statistic on people who do not tolerate progesterone. And so there are people who just don't like progesterone, meaning many things. It could and it's so funny because that's if you look at what is the side effect of progesterone, it's basically different for everybody. Some people have zero side effects. Other people will say it causes bloating and gassy and maybe breast tenderness and
yeah.
mood and depression and different things. And I would say, yeah, it's actually a high percentage of people who don't like progesterone. And so for them,
Yeah.
if they have a uterus, whether or not they need contraception, right, they could use a Mirena IUD, which is off label and still approved, meaning it's common indication to use a Mirena IUD as the endometrial protection for 5 years. You can't use it for 8, right? For contraception, the Mirena IUD is good 7, 8 years now, but you have to change it every 5 if you're using it with estrogen for menopausal hormone therapy. That's one option. There's a medication called drospirenone, which is a progesterone-only pill. Um, Brand name is Slind. And that also is an option, which you can use that with the patch. And so you're getting that is going to help protect your endometrial lining. It's also good for contraception. If somebody needed contraception and they didn't want to take the birth control pill, they can use a progesterone only pill like Slind. It can do both. And then you're getting into the older medications like norethadrone and medroxyprogesterone. Those are the other options.
Okay, but the IUD just has progesterone in it. Doesn't have
It
estrogen.
has
So you can
levonorgestrone, so it's not
yeah.
progesterone. It's
Um,
progestogen, and it's synthetic, and it's levonorgestrone, but it's really
okay.
very effective and it's locally active. And so I think that's what's important is that when you have an IUD, a Mirena IUD, it has levonorgestrone and it only is basically effective in the uterus. And so you don't get all the systemic side effects that one might have from the birth control pill that contains the same progestogen.
Right. You're not supposed to. I think is something under
Well,
3%
yeah, some people are
have
new sensitive.
systemic
Yeah.
yeah, I tried one of those, when I had a uterus. Thank God I don't have one anymore because I had really bad symptoms, but I was one of those people, I had systemic symptoms, and it was just absolutely terrible, but that is extremely rare as mu so I understand it to be
It is
yeah.
near. I've had a few people too. And then I think the other good thing about the IUD is for most people, it does not stop ovulation. And so then it doesn't reduce your naturally occurring estrogen levels,
Hmm.
whereas the birth control pill completely takes over for you and it can reduce your natural estrogen levels, which some people are very sensitive to that too. Interesting.
Right. One thing we really haven't talked about is just symptoms of vaginal dryness and pain on intercourse and the thinning and the sometimes even bleeding from thinned out tissues there. And that's one thing that we actually do treat in my office. So I'm curious to know what you generally do about that and
Yeah. So
how your
usually,
patients respond.
I like to say this to be patient. I tell them they're, vaginal estrogen virgins. So most of my patients who come to me haven't ever had vaginal estrogen and they've just been suffering. And so it's quite easy to say, oh, goody, you've never tried anything. And so you can just try vaginal estrogen and it will help you. If you're on the other spectrum of it, where you've been through vaginal estrogen creams and you've been through vaginal estrogen plus testosterone plus DHA and everything else, then I think that is when I call on you, right? I'm like, I've done everything I can to turn
Everything. It's not
it.
working.
But usually when people
Yeah.
come to me at the beginning, at least, because I'm like, oh, you're a virgin. And they're like, what? I'm like, you're like an estrogen virgin. This is great because even if I don't get them all the way better, I know they will improve somewhat. And then it's like looking for perfection, right?
I think hormones help tremendously with all of those symptoms of dryness
Oh,
and
yeah.
thinning and pain. And I will, if anyone is listening is interested, one of my earlier podcasts in season 1 was all about vaginal rejuvenation and treating those
Yeah.
symptoms. It's called the Vagina Dialogue. And
I listened to that. I liked it. I thought you guys are funny. You guys are pretty funny. Wow.
well, it's like these things are important and nobody's helping, right? We want to help. The vagina should be a happy place, not a
And
source
it's
of
also
pain.
neat because we have vaginas, and so you have these tools that you're like, you could be your own guinea pig, right? What works? What doesn't work? What feels
Well,
good? What doesn't feel good? And I think that's what it is too, is when I see, and I'm not trying to bash young women in medicine, but when I see young women trying to talk to me as a 25-year-old trying to talk to my older women about this, I had no idea what they were experiencing, right? And so it's pretty hard to talk about how the goop of vaginal estrogen cream, of why you would want to use one product over another. And anyway, so the way I do it is usually I start with a cream just because people have been without any estrogen on their vulva, vagina, all that area for a long time. And so I tell them to bathe, but then you can get a lot. You can bathe the area and then after about 3 or 4 months, usually people come back and say, I feel better, but I cannot stand the messiness of the cream. And so then we switch usually to a tablet, or there's a new a gel tablet that is a combination of a moisturizer plus estradiol. So we can,
mhm.
and then my favorite is actually the vaginal ring. That isn't like a ring that's impregnated with estradiol. And I like to say you set it and forget it, because you put it in for 90 days and then you can fish it out, pull it out, and put another one in for another 90 days. And they have those that are both just for local, because we're talking about local treatment, right? We're not talking about systemic treatment anymore. This is just a local treatment. There's a few rare exceptions, but I would say almost everybody at any time in their life, like moving on through perimenopause up to 110, can use vaginal estrogen cream
Mhm.
or these rings. The rings are expensive, but very convenient. The only time there's any
So
systemic absorption is at the very beginning. And if somebody comes in and they're very dry, this the cells, if you can imagine, are dried out, that the estrogen can pass right by them and get into the circulation. And so sometimes if that's the
mhm.
case and they really don't want any estrogen in their body, then I will tell them to use moisturizer for a few days and then to try then using the creams, try to build up that. It's not as
Yeah, and without launching too much into the whole vaginal rejuvenation sphere, just there are 2 different kinds of treatment that will actually thicken the vaginal wall, the tissues themselves, increase lubrication, and it actually those treatments also help with dribbling. A lot of women have dribbling as they get older or post childbirth. And it helps tremendously. And so there's one kind that uses radio frequency, basically heats the tissues, and there's one kind with laser that kind of resurface the vaginal tissue the way skin resurfacing works. And that's a whole separate topic, but it definitely can be helpful for people who still have issues with dryness even after they're being treated with hormones and vaginal
Yeah.
estrogen.
And then the last one is DHEA, and vaginal suppositories that are DHEA, progesterone. The brand name is Introsa. And I wish that they weren't so expensive, and I wish they were better covered, because I think that would be the next hormonal step, is that if you didn't get relief from estrogen alone, if you use DHEA, it actually gets converted intracellularly. So in the cell, it gets converted to
Mhm.
estradiol and testosterone. And so you get both. And I do think that some people need that, especially if they have pain, dyspareunia. If they have pain around the outside of the vagina, it can be really helpful to have both. And that's what it's
Yeah,
for, I think. But it's
and
very
and
expensive.
as yeah, and as you mentioned, a lot of these treatments are not covered. So it depends whether your insurance covers it or not and what portion of it. And of course, it's painful for us because we want the best for our patients, and our medical system just hasn't been oriented towards health and wellness and happiness
And
and
maybe
function. It's really
it hasn't been oriented to women,
or to women at all. Yeah.
And I think that's one of the things. I was talking to some doctors. I was just recently at and I'll put a plug in there. I was just recently at the WSMA conference, which is the Washington State Medical Association conference, where we get together and we decide on what we're looking forward in this year to trying to help out with, um, at the political level or any other level. Anyways, and these women and I were talking about how next year we should make a resolution to try to get through to the insurance companies and the insurance commissioner that hormone therapy it should not be subject to deductible, that it should be available to everybody who wants it, because it is so life changing and so life altering. And that such a shame if some woman can't afford her vaginal estrogen cream because her insurance isn't covering it. And then she ends up with 3 UTIs and then who knows, sepsis.
Right.
It's just ridiculous. And so we were talking about how even at the state level, we need to start talking about menopause and women's health and midlife health and getting these things covered, because it's not enough to just come see me. You have to be able to get the medication. And
Yeah.
when I spend a lot of time talking about the different ways you can get medication through GoodRx or Mark Cuban Cost Plus or all these pharmacies that go online and get all the coupons from all the name brands. And we try to coupon cut, but it's just, even in the end, it's just very frustrating.
I think it's terrible. Our system where we only pay for the terrible complication of things and we don't pay to prevent from happening. It's so much more costly, not just in money, but in patients' misery and your life.
But I think that in terms of getting medication access, the worst thing that I see is going to be the healthcare disparity between those who can afford to see menopause specialists like me and get medication and those who cannot. And so one of the things that I would like to work on over the next year or several years is educating primary care doctors, people who are in community health centers, people who are taking care of patients who don't have access or means to come see people like me, and to get people to feel comfortable prescribing hormone therapy and prescribing topical estrogen through those systems. And so that there won't be such a disparity, because I think the worst possible outcome right now would be that we see this health disparity that's going to happen when we discover that hormone therapy really did help promote health span, and women of they just didn't have access to it. And everybody should have access to it.
I think that the worst thing is that our health insurance just doesn't pay doctors to talk to patients and educate them and listen to them. There's no reimbursement for
Right.
talking about that stuff, right? And so there's no time in a 10-minute visit. You're really just trying to get the basics covered, make sure people have their blood pressure medication and all of
Right.
that. And all of prevention, which, has been just neglected forever, right, is just not reimbursed. So basically, doctors don't have time, even nurse practitioners, providers are poor to offer that advice to patients. And then it's not covered anyway. So
Right.
it just doesn't happen.
Yeah, no, I agree. I think that's always been what doctors talk about, is that we're not paid to think, we're paid to do. And so more procedures get done that we might need to do, because we get paid better to do things to people than we do to sit and listen and talk. So I agree with you. I think that there needs to be a shift, and especially with primary care, there needs to be more time allowed for the visit. But when somebody does come in for their 15 minutes with their primary care doctor to specifically talk only about perimenopause, that is the chief complaint, then the primary care doctor needs to know what to do.
Right.
And where I think health education and trying to get the word out and to the local residencies and things like that, so that they start building their repertoire of how do I talk to a patient in 15 minutes about this. Because
Right.
we can tell.
But even also having people just understand what perimenopause looks like so they can go to their doctor and say, hey, I think I'm having these symptoms, because even when I was having them, I didn't really recognize them as perimenopause. So in order to go to your doctor with that chief complaint, you have to have enough knowledge to know, okay, this isn't quite right. I must be perimenopausal. And I'm hoping that going forward, more doctors are able to not just dismiss that as, oh, you're fine, you're still cycling, you're fine. Come back to me when you skip a period. Yeah. Naomi, thanks so much for talking about all this today. It's been really an awesome discussion.
Thanks, Kate. It's taken us a long time to get here to this conversation, and I'm glad we had it. I hope we can have another one some other day.
Yeah, I was hoping maybe at some point we could talk about some other stuff like hair loss related to menopause. Maybe we could do that in the future.
Hair and skin and why people are putting estradiol on their face.
Yeah, that's a big topic. So we can table that and talk about that at the next time. All right. Thanks so much.
All right. Take it easy.
If you've learned something and like what we're doing, please tell your friends and give us a 5-star rating in your podcast app. If you have a question or a crazy story of your own you'd like to share, please send an email or voice recording to info@drkatedee.com. That's drkatedee.com. Or reach us through the website medspahmayhem.com. And read the book. Med Spa Mayhem is available everywhere books are sold. Thanks for listening. This has been Med Spa Mayhem with Dr. Kate D. We are so grateful you're listening, and we hope you've learned at least one fun or possibly disturbing fact today. Don't forget to hit subscribe on your podcast app and leave us a 5-star review. And read the book. Med Spa Mayhem is available everywhere books are sold. Links and more can be found in the show notes and on medspahmayhem.com.